So today's ECG is a bit of a weird one. It's the type of knowledge that you can take. One day you decide you want to be an anesthetist, you want to be a physician, maybe you want to become a surgeon, and you can pull out the term, and everybody will be like, wow, you actually know what this is, but at the same time, you'll be saving somebody's life. Don't worry, right? So this ECG that we're going to show you today is not actually going to be very easy to pick out where the problem is. We're able to pick out that there is a problem, but it'll be very difficult to say what the problem is, and I want to teach you what the problem is, all right? So let's go for it so that we can see, right? So this is our ECG, right? So as usual, just to go through the steps, we analyze axis, analyze rhythm, P waves, PR interval, QRSs, QRS after every P, regular groupings, analyze rate, analyze each zone, right? So this is the one that we are looking at, okay? So let's go to the actual ECG and work it out, right? So here we have a 47-year-old woman with chest pain, right? Chest pain, now pain-free after using TNT, all right? So our first thought is ischemia, agreed. So, I mean, TNT relieves ischemia, it causes vasodilation, normally allows for a bit of flow, it allows everything to go on, So we need to have a look through the ECG to see was there ischemia or wasn't there ischemia at the end of the day. All right. So let's have a look and see. First of all, let's just get this here. Right. So let's start with the axis. Okay. Come in, don't worry. Okay. So let's start with the axis, all right? So let's look at lead one. Lead one is pointing upwards, eh? So we know we either have a left-sided axis or a normal axis, right? We don't have a extreme right, and we don't have a right-sided axis. Agreed, Dr. Coulson? Okay, you have to agree. You say anything else, it's a problem. No, I'm joking. All right, and then let's look at lead AVF. So which way is lead AVF pointing? Up or down? Or up and down? Neither up nor down, isn't it? Biphasic, correct? So let me just put this on the video panel as well. Okay. So when we say biphasic, all right, so if we look at this one here, biphasic, right? So look at where lead AVF stands. It's right at the bottom. Okay, so imagine now I'm lead AVF. So what's happening when you see biphasic? What it means is that for a while, lead AVF is following electricity coming towards it. And then at a certain point, it sees it going away from it, all right? So the only way that can happen, that it sees it doing that and doing that, is if it's perpendicular to how the electricity is flowing. Do you get what I'm saying? All right. So in reality, what's happening over here, and it's a good trick to remember, is that lead AVF, actually electricity is traveling in this direction. All right. So it's starting from this side. So lead AVF sees it coming as positive, and then it starts moving away. So it sees lead AVF as negative. So in essence, what we have is that we have a axis that sits more or less there at 0. Okay, so it's a normal axis, basically, right? It is a normal axis. That's what we're trying to say. So in other words, in this case, the axis is not telling us much, right? Let's go to the rhythm. Okay, so we've got a nice long rhythm strip over here. So let's have a look at it and see. So let's look at the P waves. Do they look normal to you? Just how they look. Some look normal, some look abnormal, some look like a thumb, some look pointy, some look like they're leaning this way, some look like they're leaning that way. So even if you don't know exactly, but is it normal? Let's put it that way. Okay, so something wonky is happening. Agreed. Even if you don't know exactly what it is, right? So the first thing to remember is that the first half of the P segment looks at the right atrium, second half looks at the left atrium, right? So even though we're not getting into atrial abnormalities, just for the sake of it, you see here there's a P, it's prolonged in the R wave. So the right atrium is kind of enlarged a little bit, and at other times it's not enlarged. So it comes back to normal. Then it has sort of an enlarged picture again and things like that. So there may be something happening with the right atrium, just for example. Right? Then we look at the PR interval. So it should be between 2 to 4. All right. So our PR interval, let's take it from here. We've got 1, 2, 2.5. So it's about normal. All right, just within normal. Our QRS complexes, are they narrow or wide? When you look at them, quite narrow. Right? They're not really that better. All right, then does a QRS follow every P? It does. And are the groupings regular? Quite regular, isn't it? So except for that funky P wave, everything else looks more or less okay. Right? So we could say maybe there's something happening with the right atrium or something like that. Right? Okay, and the rate for this thing here is 1, 2, 3, 3.5. So about 80 somewhat beats per minute. So far, nothing too hectic. Right? All right, so let's look at each zone and see what we can see. So let's start with the inferior zone. So the inferior zone, or the leads that look at the inferior part of the heart, are leads 2, 3, and AVF. So what looks abnormal in those, or any abnormalities that you can pick up? Because remember, this lady did have chest pain. So what did you notice? Very good, yeah. So we've got a T wave here in lead 2, eh? That's upside down, it's upside down there. In lead 3, if we had to just concentrate on the T wave, what do we notice? Yeah, it's kind of flattened, kind of absent, all right? And if you look at lead AVF, what do we see? Yeah, inverted, shallow, even a bit prolonged. You know, it's taking a bit of time for that Q wave to come, right? So there's something happening with the Q waves there, right? So let's look at the septal part of the chest leads, all right? So we've got V1 and V2. What do we see there? Let's look at V1 first. Anything in particular that we notice? I would say just that this QT looks a bit long, eh? And this is not really a Q wave because it's not deep, not pathological. Okay. What about V2? We learned about this last week. This M pattern is called a bundle branch block, isn't it? Right bundle branch block, but it's less than 4 blocks, so it's an incomplete right bundle branch block. All right. And we start seeing these T waves that are going, but so far nothing specific. I mean, it's all non-specific. We're not seeing anything specific. And let's come to the anterior part of the heart. So V3 and V4, what do we see? Yeah, very good. They're inverted T waves, but what else do you notice about them? Sorry? Yeah, they are a bit long, but they're relatively still normal. I'm talking specifically about the Q waves themselves. What do you notice about them? I mean, this is an inverted Q wave. This is also an inverted Q wave. What's the difference between the two? This one here looks more wide, narrow, wide, symmetrical, sorry. Have you ever heard of hyperacute T waves in ischemia? Or basically long, tall T waves that are pointing upwards, all right? Okay, if you remember hyperacute T waves, this is also almost like the opposite of that, you know? They're like falling the other way, you know? So it's like something that's fallen, you know, completely the other way, but it doesn't look normal, that's for sure, right? So it's these deep symmetrical T waves, all right? So number one, are you already worried? Even if we haven't gone any further, just my question to you guys. Would you put this patient on antibiotics and Panado and go home? Okay, that's good. Just know you're not going to do that. That's fine. All right. There is something going on with this heart, even if you don't know what exactly it is. All right. And we'll get to what it is just now. All right. So let's see. So in V3, we've got these deep, inverted, symmetrical T waves. We get to V4, what do we notice? Similar T wave pattern, isn't it? And you could even argue there's maybe a little bit of ST depression over there, right? Even though it's very slight, but you could start arguing there's a bit of ST depression. And what do we see in V5? Not so much in V6. Again, with the T waves. Again, they're inverted, they're deep, they're symmetrical, things like that. There might even be a little ST depressions and things like that. Okay. And then let's come across to the other side. So we remember V5 and V6 are the lateral leads, and leads 1 and AVL are the high lateral leads. All right. So these are supposed to give you a similar picture altogether. So what do we see in lead 1? Also this inverted T wave, all right? Maybe an ST elevation. Here we see again a slight inverted, long QT, things like that, all right? So there's quite a few things that are happening. And then the last one is AVR. And what do you see in lead AVR? Specifically here, what would you call that? Let me draw. Yeah, 100% right, yeah. Because let's start a line from there. All right, so this you could do with, what am I drawing? I'm supposed to draw. To draw this, right? So let's start from there. Oh, nice, how are you? Let's run it all across. So we can see that if that's the isoelectric line, this ST segment is ever so slightly above it, right? Not by a lot, but it is there. So there is clearly a slight ST elevation as well, right? So what's your plan now? What are you going to do for this patient? Even if you don't know the answer, I'm going to teach you the answer because it's something that's not common. It's not something you see very often. It's something that you must remember because you'll impress people later on. But the question is, looking at your history, 47-year-old woman with chest pain, now pain-free after use of TNT. So she had pain, her arteries were clogged. Why do we say her arteries were clogged? Because the ECG is all messed up, all right? So chances are there was a blockage, okay? She used TNT. TNT is a vasodilator. So that means she reperfused, which means that she's no longer in pain because she is reperfusing, okay? So what do you think is happening to this patient? How are you going to manage this patient? Because TNT is not a forever drug. It's not like you give TNT now and the patient, until she's 87 years old now, she's fine, you know, everything's okay. What's going to happen when the TNT wears off? It's going to fall back down again. Agreed. Okay. So I'm asking just in terms of management. Are you treating her as a suspected ischemia? Yes or no? Yes. Okay. So are you going to give her oxygen? Are you going to give her morphine? Are you going to give her TNT on demand? Yes, you are. You are going to do all of those things. All right. But then are you going to wait for enzymes, for example? No, you will. Most of the time, you will wait for enzymes. All right. The problem is then your enzymes come back as normal. In this patient, I'll tell you specifically, it will come back normal, to close to normal. All right. There's two reasons for that. Sometimes enzymes take up to 6 hours to rise, or the patient reperfused. Because when she took TNT, blood went back into the heart. The damage was controlled. So there's not that much enzymes that are being released. So you may well find that your enzymes are not that high. So if your enzymes come back as normal, are you still sending her home with Panado, Tramadol, and TNT PRN? I wouldn't. There's something going on here. Agreed? Okay. So even though you're not 100% sure of what's going on here, something is going on. So there's a few ways that you could look at this, for example, from things that we've spoken about before. Number one, we have a whole lot of ST depressions. So this could be an NSTEMI, for example, all right? And if it were an NSTEMI, we would re-ECG after 10 minutes or 20 minutes or at hour intervals and look for dynamic changes and things like that, all right? And if there were changes, then we would say, no, this is a high risk and not just an NSTEMI, this could be a STEMI. One of the things we learned earlier in the year is that if you have an ST elevation in AVR isolated, it tells you that it's a main stem or proximal LAD, right? Left anterior descending artery blockage. Normally just gives you this, this increase ST elevation AVR. The most important thing is you're not sending this patient home, all right? But now I'm going to add one more trick into your arsenal, all right? So that you know and you have something clever to tell people. This pattern of very deep, wide ST depressions all across your anterior and even your lateral segments is something that we call Wellens syndrome. All right, we're going to get to that just. Okay, I'll explain to you how it happens. All right. So let's say we had a sinus rate of 85, incomplete right bundle branch block, T wave abnormality consistent with inferior and anterolateral ischemia. All right. In 1982, Wellens and colleagues described two T wave morphologies in the mid-precordial leads that are highly specific for proximal left anterior descending artery obstructing lesion. The more common morphology is symmetric deep, which is what we saw. The less common I'll show you just now, right? The T-wave abnormality, which has come to be known as Wellens sign, usually persists even in the pain-free state, all right? Medical treatment is often unsuccessful in preventing MI or death. Invasive therapy with angioplasty or stent placement is more successful. This patient was found to have a greater than 90% proximal LAD obstruction. She was successfully treated with angioplasty. Now we get into why that happens, right? So what I want you to remember from this, you see a fishy ECG. Even if you can't put your finger on it, you're not 100% sure. But what you remember from this lecture is that deep, wide, inverted T waves all along these mid-precordial ones, right? All along these mid-precordial ones are present in a patient that's pain-free. Very important, pain-free, okay? The reason why I mentioned that, one of the differentials or one of the things that's very easy to mix up with this is pulmonary embolus. Because in pulmonary embolus, we also say, look for deep inverted T waves along the precordial and inferior leads, right, to make your diagnosis. But patients in pulmonary embolus are not pain-free. They generate dyspnea, struggling, they have a lot of chest pain, things like that. These patients, on the other hand, become pain-free. And I'm going to explain to you why in just 1 second. Now, these are the waveforms that you see, right? So this is what we were seeing, right? And this is called a type B. If you in 5 years' time, if you remember, hey, you've got a type B Wellens, they'll probably carry you on their shoulders around the hospital, like, wow, you know, such a great doctor, right? But even if you can remember it, right, it's great, okay? And this is a normal inverted T wave, all right? So you can see it's deep, but not as symmetric. It's the symmetry here that's so important, you know? The way it decreases and increases is very different from that, right? And one of the other less common ones is you get a biphasic T wave here, right? So the question is, why does it occur like this? The question is why? Why are you seeing all of this? Wellens is actually what they call a reperfusion rhythm, which is why it looks like that. So I just want to draw it up for you here. So what happens initially in most of these patients when they are sick or when they are having their pain, if this is their artery, it's completely blocked, okay? That's when they are experiencing their pain. And the majority of their time, their pain is due to a thrombus that's sitting over there. Or alternatively, things like cocaine with vasospasm, or atheroma plus plaque, things like that, all right? And then what happens is after a little while, either they use TNT, they use aspirin, things like that. Then what happens is a piece of the clot diminishes or goes away. So instead of having complete blockage, they have partial blockage. And when they have partial blockage, they start actually looking exactly like somebody who's reperfusing, right? Because when we reperfuse patients, this is what it looks like as well. So they're pain-free, everything's okay, everything's going well. The problem is this is very volatile, extremely volatile. So what is going to happen is that in the next hour or two, they're just simply going to go back to that, all right, and die. That's the sad part, okay? So in other words, be careful of the patient who has had pain, now is pain-free, but presenting with these types of T waves, okay? What do you need to do for this patient? Doesn't matter how much alteplase or streptokinase or whatever it is you give them, they're never going to recover. These are the patients that you transfer to a cath lab because they need to have all of that muck moved out of the way, because the proximal LAD is supplying most of the anterior and lateral side of the heart. So if it gets blocked again, they're just going to die. Okay. Now, it seems like a strange concept. It seems like something you won't see very often. And it's true. It's not something you will see very often. You'll see it once every 2 years, maybe once every 3 years if you're working in emergency department. I've seen it 3 times here. All right. We've saved all 3 patients. Okay. They're all walking around. They're fine. They stented. Everything is okay. But the important thing is to recognize it. Okay. The worst thing you can do for these patients, wait for enzymes, wait for the physician to come out, wait for them to say they want to thrombolize, do the thrombolytic checklist. They're wasting time. The patient's going back to what they were before. You need to be able to, in 2 years' time, remember, Dr. Mohammed said something about these inverted T waves. It's not right. Quickly Google inverted T waves pain-free patient. Wellens just pops up on Google and Bing, because I checked on both. All right. Unless you use Opera or something, I don't know what it will tell you there. All right. But on Google and Bing, it shows you Wellens sign, T wave inversion, danger, da 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 da. So you know immediately something's going on. So you start preparing this patient to go in for PCI, right, and angioplasty and stent, right? Because what's happening is you have an artery that's blocked, that's just been open for a little while, but has the potential to just close up again. And generally, when it closes up the second time or the third time, that's when you have a problem. There was a very interesting case I was thinking of putting on here, but I figured it might fry people's brains on a Monday morning. It was actually a stuttering one where they showed about 5 ECGs of a patient who actually started off with what looked like a full STEMI, then changed to this, then started reperfusing, went to that, went back to not reperfusing properly, so went back to that, then went to complete MI again. So it's amazing like how the patient changed. It's an odd case. If you have a chance, just go and look for stuttering Wellens. There's a nice case that comes up on it. But the most important thing is to remember deep symmetrical T waves, right, in these precordial leads. Could be Wellens and could be pulmonary embolus as well. Generally with pulmonary embolus, your patient has pain, dyspnea, all those things that come along, and they generally have a right-sided axis as compared to our patient that didn't have. And remember, there's other things like P pulmonale, there's a rotation of the heart, there's a whole lot of things. There's precursors like DVTs of the legs, you know, on cancer treatment things, whereas these patients don't have all of that. And these patients are actually sitting comfortably. They come to you and they say, I was in pain 2 hours ago. I took my tablet. I'm perfectly fine now, but I'm just worried. Okay. But they're ticking time bomb waiting to drop dead. Okay. So remember, Wellens. Okay. Just keep it in your mind, Wellens. One day you'll impress a consultant and you'll get a reg post based just on that. Okay. And if you can remember type A and type B, I think they'll give you your fellowship immediately. You can just walk on. So it's just an interesting thing to know. The reason why I mention is if you miss it, this patient will die. If you get what I mean. Because now you've got a pain-free patient sitting there, everything looks okay. No, it's okay, don't worry. We'll put you in the ward and you've killed the patient. All right, that's the thing. When I say it's relatively uncommon, it is relatively uncommon, but we do see it. It's not like you'll never see it. Just keep in mind these deep inverted T waves. Okay, just remember that. And when it does happen, even if you can't remember exactly what it is, ask somebody and then we'll take it. Okay, any questions? Besides Tobila, we immediately shook it. I want to get back to seeing real shit, not all of this theoretical nonsense. One of the other reasons why I picked this is just to show you, sometimes it's very good. ECGs can have some weird patterns. Now, I mean, if somebody were to just show you this and you had never heard of it, just the fact that you recognize something is wrong, I'm happy. As soon as you guys all in unison said, no, we're not sending this patient home with Panado and then, you've already done very well. You saved your patient because you are going to ask somebody. Now, that person who you asked me also look at the ECG. What the hell is going on here? Yeah, wait, I just want to check one of my books. In the meantime, they're phoning Dr. Fazbom. Doc, I don't know what the hell is happening. I'll send you a picture. Tell me what's going on. You get what I mean? But at least it's getting passed up the chain until somebody says, this is Wellens, let's get this patient ready for PCI. That MO will come back and say, no, you should have known it was Wellens. Why weren't you preparing for PCI? You know, they'll come back like that. But if you didn't pick up the initial problem, there was nowhere for the patient. So I always tell you, recognize the normal. And when any of these abnormalities come, even if you're not sure what it is, but at least you can ask. Okay, good. All right. People on Zoom, if you all have any questions, you can ask me over the chat later. But I think for now, we're going to end. And I hope everybody enjoyed it.